Welcome everyone. This is Dr. Jaitly, your cardiologist on your favorite video site, which is MuniMeterHealth, where we enhance medical education and patient education together to improve the clinical outcomes, which has been my deepest global initiative, in fact, and that's why I'm reaching out to all my patients and the medical fraternity through this medium. And I thank you for joining us on MuniMeterHealth, your site for enhancement of education. Remember, this is only an educational channel. It's not a substitute to the syllabus, my dear medical students. It's always a supplement to it and not a substitute. And of course, it's if you're having an emergency, please go to the nearest hospital and consult your doctor right away, or dial 911 if you're in the United States. So having said that, my housekeeping rules has been kept aside now. Let's worry about what's the subject today. So without any further ado, today we are going to talk about cardiac MR. Does it help in the HOCM? Now, that's a question because, cardiac MRs are not freely available. We know that. Many of the centers, even in America, do not have cardiac MRs around the block. But the fact is that I think it's a very advanced technology, and certainly in the past 8 or 10 years, we have really galloped away with the so-called information that's coming through. And most of us, we infer that now. Again, transthoracic echo, we know that has been around for like almost 20 to 30 years now. And the transesophageal echo has been around also for almost 20 years. So these are the various techniques which people have employed where they can sort of, be complementary to certain informations when they're diagnosing IHSS or HOCM or ASH. And by the way, this is the only condition which has, in cardiology, has so many names. So idiopathic hypertrophic sub-aortic stenosis, again, students, please do not get confused. It's all the same. Hypertrophic obstructive cardiomyopathy, a HOCM, or asymmetrical septal hypertrophy, as it's called, ASH. So they are all synonymous, just so that you know, and this is the septal hypertrophy. The definition of septal hypertrophy is clearly that you need to demonstrate a ratio of 1.3 to 1.0 between the septal wall and the lateral wall. Now, this is your lateral wall and this is your septal wall. So if you demonstrate that ratio, then you're starting to clinch the diagnosis of IHSS. So that's one criteria. 2, you need to demonstrate a little bit of asynergy or dyssynergy, if you will. And dyssynergy normally exists only on an echo, and you can show that on the wall motion abnormalities, etc. So that is another issue. And many times you can also show an LVOT obstruction or left ventricular outflow tract obstructive pattern. And once you demonstrate an obstructive pattern, you demonstrate that there is a subvalvular, because obviously it'll be a subvalvular obstruction here, and that is what is causing the pressure gradient in the Dopplers, and they are very hemodynamically dynamic, I would say, what you may call obstructive gradients. In fact, aortic stenosis has a fixed gradient, whereas an obstructive pattern in an LVOT secondary to IHSS will have a more gradient during the systole itself as the systole progresses, and for obvious reasons, because remember, the obstruction is sitting right in the septal wall here in the left ventricular tract area, and there is a certain amount of dyssynergy, and all of that will really contribute a great deal to the LVOT obstruction, which is a dynamic obstruction. And then again, you can do several testings during provocative testings, like during the stress test, or while the person is walking, or even while certain obstructive provocative tests one can resort within the labs, again with a very, very close cardiology and a cardiologist monitoring. So anyway, so cardiac MRs in general, again, if you're using the gadolinium, now there is a contrast gadolinium. Now that really highlights a few things very easily. Now that's where we are. So we are looking at the intra-myocardial, we call it intra-myocardial scarring, for instance. Now that is a potential danger for future what you call lethal arrhythmias, and therefore sudden cardiac death episode can ensue. So intra-myocardial, if you will, if you were to look at the scarring, you will be able to see that through the gadolinium cardiac MRs. So this is very, very important. In fact, the structural features of the cardiovascular system and the functionality both have been really better understood. A complete anatomy of the heart can be better understood with the cardiac MRs. So this is where we are. Apicals, there's a certain degree of apical hypertrophy present predominantly in the Japanese populations, and we have seen apical variants of HOCM, if you will, or sometimes they just write HCM, Hypertrophic Cardiomyopathy. So if it's an obstructive or otherwise. So apical variety can be seen in Japanese and Far East Asian populations. Probably a genetic predisposition, but still we do not know the reasons why there is a propensity in the Asian and Japanese populations. But nevertheless, apical is very, very hard to be picked up on a transthoracic echo. As we know, when you're doing an echo, for instance, if you were to do an echo, you will have, say, a window here like this, and obviously here is your the aorta, and then this is your mitral valve, and this is your posterior mitral valve leaflet, and this goes into the left atrium, and this becomes your posterior wall of the left ventricle wall, and again this continues as your septum, if you will, and this becomes your septal wall. I'm showing the septal wall here in this fashion, but the apical, which is this apical portion, is the tendency is not to be seen so easily, and again this becomes your and your right ventricle is up here. So anyway, so this is your septal wall, and the septal wall tends to be hypertrophied, so that could be identified, but the apical part sometimes is missing, and you may not be able to see that very well in the long axis view. Now, even if you try the apical view many times, you may not be able to, if you do the 4-chamber apical view, for instance, there also you will not be able to see so distinctly and be able to discern whether you're dealing with thrombus, whether you're dealing with maybe a scar, or whether you're dealing with an apical form of HOCM. So again, these are the rule outs, for instance, and that apical, even in apical view, as you know, this being the LV and this being the LA, RV, and this RA, just for orientation for my medical students in residence. So, you understand this, the thrombus may not be identified, the scar may not be identified, and everything is like quote unquote, we don't know so it becomes almost like a rule out. So differential is there. And T is definitely not good idea for apical if you were to look at, because that's very, very far from looking at, because apex you will not be able to see when you're doing a transesophageal. It's better to see the left atrium, mitral valves, and maybe the aortic valve and the aortic root or the aortic arch, but not good for apical. If you were to look for T, is not a good, and that may be one of the questions on the boards. They might ask you, out of all of these testings, which is not a good idea, which is the least visualized, and that is T will not help visualize the apex as well. Okay, so now, intramyocardial scarring and apical HOCM, and especially the HCM, that's where the gadolinium contrast, if you will actually stand out very well. As I said, thrombus. Now, thrombus, especially in a burnout phase, if you have a burnout, we call it a burnout. In the later stages, what happens is the HOCM again, sort of quote unquote, the muscle wall weakens, and the thrombus will start to sit here, and this could be a thrombus. And because you have a thrombus sitting in the burnout HOCM, that could be missed, and therefore, again, as I said, like in this setting, you cannot see the apex too well in a transthoracic. And likewise in the TE, whether it's a long axis view, which is here, and this is your apical 4-chamber view. So you're looking at not such great help here from those modalities. So therefore, cardiac MR again stands out very, very importantly, where you can see a thrombus too. And lots of other mimicking. I call them mimicking. Why? Because you could be mimicking a hypertrophy here, and we know that many times on transthoracic one does not know, especially in the aortic stenosis, for instance. You could start to have concentric hypertrophy, but septum may start to hypertrophy hypertrophy a little earlier than the lateral wall, and one may say, oh, by the way, this is an IHSS that's developing, but actually no, it's actually the aortic valve which is narrowing, and that could be the reason. So again, mimicking aortic stenosis, if you will, that could be one of the reasons. And second is hypertension. And hypertension, do not ask me that question now because I don't have the answer. And that is, many of them will have eccentric variety of hypertrophy, and a lot of them will have still concentric. Of course, predominantly it's concentric hypertrophy, but it could be befooling, and many times you may have multivalvular disease. Now, multivalvular disease, especially if you have an MR and AS or AI and AS, etc., so they could also lead to some asymmetrical hypertrophy, if you will, and eccentric, and one may not know whether this is a true septal hypertrophy, etc. But the fact is that if it's presenting in a younger individual and there's clear history of chest pain, syncope, and or lethal arrhythmias, or near lethal arrhythmias, I should say, and of course you have a gradient which is established, subvalvular, and showing the hypertrophy of 1.3 to 1.8 ratio, that'll clinch the diagnosis of IHSS more or less anyway, and that's where the suspicion rises. So you start working up these patients after a transthoracic echo and then take them to cardiac MR. Okay, so the question, cardiac MR, do they help in HOCM? Yes, because obviously you're looking at intar-myocardial scarring, and specifically so because these patients are potentially, prone for arrhythmias and sudden cardiac death if you can demonstrate an intar-myocardial scarring. Remember, there's dyssynergy, there's this asynergy, and the whole pattern of contractility and even the structural nature of the disarray of these myocardial fibrils, if you will, they could be sometimes seen. Sometimes you could see them in transthoracic too, but I think gadolinium cardiac MR is definitely there to highlight those much better structurally as well as functionally. And likewise, the thrombus in the burnout phase and certain conditions of LVH which could mimic the IHSS, they could be prevalently seen in the gadolinium contrast of cardiac MR. Okay, I thank you for your attention. Again, stay well and stay on MuniMeterHealth, your favorite site for education, as we always say. Thank you, and this was Dr. Jaitly. So long, and see you on the next video. Bye now.